thank you for inviting me to speak to you all today about my field of research, which is fungal infections. Something I'm quite passionate about in my work is not just my research, but also to raise awareness of fungal infections and why I think people should know about them and be aware of them and why they're important. So I'm going to start off by giving you a bit of an overview of the fungal infections generally and why I think they're important, and then I'll go into details and give you some examples of fungal infections and why they're particularly important in healthcare settings and how we can better manage them. So my lab studies research into immunology and immune responses of fungal infections. So I'm going to give you a few reasons why we study fungal infections. The first is that fungal infections are really quite persistent. So we think around a quarter of the world's population at any one time has a fungal infection. This is usually a mucosal or a skin infection. So a really common one, for example, is vulvovaginal candidiasis, or otherwise known as thrush, which we think affects around 2 billion women every year. But there are many, many other fungal infections. And while these are not typically life-threatening, they do cause significant distress to people, particularly if they are recurrent sufferers. Now, my lab studies the other kind of fungal infections, which are much rarer, which are the life-threatening fungal infections, and these are the ones that kill people. So these are sometimes referred to as systemic or invasive fungal infections, but cumulatively every year they kill around the same number of people as TB, and about twice that of malaria. And yet most people of the public would know what malaria is, they know what TB is, but I think a lot of people would struggle to name an invasive fungal infection, despite the fact that they have a very significant impact on global human health. There's many different types of invasive fungal diseases. The majority of these deaths are caused by a disease called cryptococcosis, and I'll tell you a little bit about that one later on. And the other ones I'll tell you about are candidiasis and aspergillosis and pneumocystis, which make up the other major causes of death from fungal infection. Now, one of the reasons we see very many deaths from fungal infections is because of their upper mortality rates, and this distinguishes them from other types of infectious diseases. They are very, very high. So some of the upper mortality rates for some of these infections, something like mucormycosis, for example, it's quite a rare infection, so you don't see huge numbers of deaths, but you have a 90% chance of dying from that infection if you catch it. And that's despite the availability of antifungal drugs. So these are infections that are really quite difficult to manage clinically and kill a very large number of people. One of the reasons we see, again, these high mortality rates is because of our diagnosis and treatment is really quite limited for fungal infections relative to other types of infectious diseases. For example, there are no available vaccines to prevent patients from getting fungal infections. There's a couple in clinical trials coming through, but it's very, very difficult to make a vaccine against fungal pathogens. We also have very limited antifungal drugs available. Now, the antifungal drugs we do have are very good. They work well. The problem is we have very limited numbers of classes of antifungal drugs compared to something like antibiotics, where we have many, many more choices available. Part of the reason for that is because fungi are eukaryotic cells, just like our own cells. Animals and fungi are actually more closely related than fungi are to anything else. And because of that, the biochemistry of a fungal cell is very similar to our own cells. So it's quite difficult to find new drug targets that are not going to cause toxicity to us. And then, more worryingly, of the antifungal drugs we do see an increasing rates of antifungal drug resistance to the drugs we do have, which means that some of the drugs that we have on the shelf are now becoming less useful to us because of the rates of resistance that we're seeing. So many of the fungal infections that we see typically affect vulnerable people, and this is usually caused by defects in their immune system or their immune responses. And so for that reason, most fungal infections are healthcare associated. They affect people who are living or have been under long-term hospital care. Risk factors can basically include anything that will cause any sort of immune system dysfunction or disturbance. So this can range from congenital or inherited mutations, which tend to be a bit rarer, but the majority of them tend to be more acquired, and this is usually a medical intervention of some kind. So it could be long-term use of antibiotics, IV catheters, cancer treatments, and various other types of infections as well. So for example, we saw some big waves of fungal infections, particularly that used to be rare, like mucormycosis in the COVID-19 pandemic, for example, in some countries. So we're seeing these kind of co-infections coming through as well. So I'm going to tell you now about three of the sort of big killers of fungal infections, tell you a little bit more about them and some of the work that we do in the lab to try and figure out how best to manage these things. So the first one I'm going to talk about is candidiasis, which is probably one of the most relevant ones for here in the UK. So candidiasis is caused by a fungus, mostly Candida albicans, but there's a lot of non-albicans species that are on the rise in the last few years as well. It normally exists as a yeast, like a little budding yeast that you would use to make your bread. Of course, this is a different species, but it's the same kind of cell. Now, it's actually quite a common component of the microbiome, so most of us have it in our guts. It's a normal part of the commensal there. But if you have a nice, healthy immune system, you wouldn't even know it's there. It's not causing you any problems. It's when the immune system starts to get disturbed that we start to see issues with this fungus. And if allowed to, it can start to form these long filaments called hyphae. And these are very inflammatory and very damaging to the body. So they can burst through blood vessels, for example, and invade into tissues. This here is a biopsy of a brain from this patient, where you can see the fungus, which is stained in black. So you can see all these hyphal cells in the brain tissue. And this is a patient with a scan with this brain candidiasis, and the arrow is pointing to this large fungal mass in the brain. So she was extremely unwell, and this was caused by a genetic mutation that she'd inherited that made her more likely to get this type of infection. So we see around 350,000 patients per year, sort of globally, of candidiasis, give or take. It's kind of difficult to know exact numbers because not all of these fungal infections are reportable, so it's quite a lot of hard work to get the epidemiology right. The mortality rate's around 40%, and again, that's with antifungal drug treatment, so still a very difficult infection to manage. Some of the major risk factors, one of the main one is neutropenia. So this is where you have reduction in the circulating white blood cell called a neutrophil. It's quite a common feature in patients on chemotherapy, for example, but also patients who are in like the ICU, for example, after acute trauma and so on. Antibiotics are also a major risk factor. So if you have patients in hospital or on long-term antibiotics, this is a major risk factor for getting this disease, as is the use of intravenous catheters. And that's partly because this fungus can grow in the plastic of these catheters, and actually you can cause direct infection that way. Now, one particular species I wanted to mention, because I think it's relevant for healthcare settings in particular, is Candida auris. This is a relatively new fungal species that has risen up in the last few years. It's really the first fungal superbug, so I think we're all aware of things like MRSA. This is kind of the equivalent of that, but for fungus. Now, it's an unusual fungus. It exists as a yeast, just like Candida albicans that I showed you. This is what it looks like under a microscope. It's quite unusual, is that it can grow up to 42 degrees Celsius, and that's a little bit weird for fungi. The vast majority of fungal species do not like being hot, they like being cold, and that's why they're usually found in places like the soil or in plant life and things like that. It's the few species that have this temperature adaptation that can grow at our body temperature that tend to cause infections. So this one can go even further than that and is a little bit unusual in that. The reason we care about it and why we're worried about it in healthcare settings is because it's inherently resistant to at least 3 classes of antifungal drugs, which means that before you even start to treat a patient, you're already going to struggle because a lot of the drugs just won't work with this fungus. And then unlike other types of fungal infections, so most fungal infections are not infectious diseases in the sense that you can't catch it from patient to patient. We don't make the spores and spread it the same way you would a virus. But we do see clusters and outbreaks of Candida auris cases in care homes and hospitals. And part of the reason for that is because we think the fungus colonizes the human skin, which means if it's on the skin of healthcare workers, it can then end up on door handles and bed rails and bedside tables. And we think this is what causes the spread, particularly if you're looking at a population of people whose immune system is maybe slightly on the damaged side. And then this is a map just of spread of Candida auris and across the globe. So we really started seeing the first reports of this fungus in 2009, so that's how recent it is. And the countries in red are showing you countries that are reporting Candida auris infections over time. And what this kind of gives the impression of is that the Candida auris sort of started in one country and then spread around the world. But that's actually not what we think has happened, because when we take genetic analysis of fungi from all these different continents and compare them, they're all completely different. And so what that means is that this Candida auris has arisen independently in all these different continents in a very short space of time. We're still trying to figure out why that would be, but the working theory is it might have something to do with climate change and the growing global temperatures, because this fungus is very well temperature adapted. And if our temperatures are rising, fungi have to adapt to this. This then endows them with properties, which means that they could then potentially cause infections. And actually, in recent years, we've now seen some infections of very unusual fungal species that never cause human infections, and we're now seeing them in patients. There's also some interesting research showing that if you expose some fungi to higher temperatures, they start picking up mutations, which then confer drug resistance. So this is also another concern and something that a lot of labs are now very interested in understanding in more detail. So some work that I was involved with a few years ago now was trying to understand how Candida auris actually colonizes the skin and any methods we could use to try and counteract that. So this was some mouse models that we were using. So the blue line is just normal healthy mice, And in the red line are immune deficient mice. So these are mice that would have damaged immune systems like we would see in patients. And then basically we put the fungus on the skin, and then we did swabs and then measured how much fungus could we get off that swab at different time points after doing the initial exposure to the fungus. And you can see immune deficient mice really struggle to get rid of this fungus. Once it's on their skin, it's there for ages. And then this is some microscopy. So this is the fungus in black here. So you can see sitting up close on the surface of the skin. And then this is a hair follicle, and the fungus can get deep into these hair follicles, and this is where it can kind of hide and stay there. And this helps spread it around, in this case, their cages. One thing we explored to see if we could counteract this, is that working? There we go, was chlorhexidine wipes. So quite commonly used, and so we did a sort of animal model, just kind of a sort of proof of principle, where we put the fungus on, and then we were doing these wipes with chlorhexidine, comparing it to mice that just got normal wipes, and then looked to see if we could get rid of Candida auris from the skin. And that's what these graphs are showing you here, comparing control wipes to chlorhexidine wipes at different time points. And what we found was that these immune deficient mice, which get very high burdens of fungus on their skin, can be more effectively controlled if you use the chlorhexidine wipes. So we put this, that this might be a good something to consider if you suspect that you've got Candida auris outbreaks in your healthcare setting. Okay, so I'm going to move on to talking about this one now, which is Aspergillosis and Pneumocystis. Two very different fungi, but they typically cause very nasty lung diseases. Aspergillosis, in particular, is a mould, and this is what it looks like under the microscope. So it forms all these little spores, which are sometimes called conidia. There we go. So the main species that cause these diseases are Aspergillus fumigatus and Pneumocystis jirovecii. Around 300,000 patients per year. Very wide mortality rates, starting at around 30%, going up to 90%. And that sort of depends on the underlying health disorders of the patient, but also where the fungus gets into. So say this is what the fungus looks like. It forms these little spores, which then become airborne. And we inhale these things all the time, so we all will have inhaled at least a couple of these spores today already. They're found in the environment everywhere. But if you have a healthy immune system, it will just get destroyed with spores. They won't go any further. What we tend to see, though, in patients who have any kind of immune cell defects, so particularly stem cell transplant patients, any kind of lung transplant patients, any patients with things like cystic fibrosis or COPD, any other sort of lung problems, that's when this fungus can then start to maybe not get cleared as well, and then can germinate and cause problems. And if it escapes from there, if it's not well managed, it can get into places like the brain, and that's where we see the very high mortality rates with these types of infections. Now, the important point I wanted to make with these particular types of infections is about drug resistance. There we go. Because we think the drug resistance in molds in particular are being acquired in the environment, not in healthcare settings. So this is a study done just a few years ago now, looking at isolates in the UK. And what the pie charts are showing you, what the colours mean, are different mutations that confer resistance to a different type of antifungal drug. And what the authors did was they took isolates from things like flower boxes and fields and soils near hospitals, and then looked at the isolates they found there compared to the fungal isolates from patients that were being treated at the local hospitals. And what they found was that the mutations were the same. So what that sort of suggests is that the drug resistance that is being picked up by this fungus is happening in the environment, not in the hospital, which means that if you have a patient come in with a fungal infection, before you've even given them a drug, they're already resistant to some of those drugs. And that's a problem. Now, we think that the reason that we see a lot of environmental drug resistance being acquired is because of widespread use of antifungal drugs in agriculture. While fungi cause really big problems in infections in people, they also cause big problems in infections in plants, right? So farmers need to protect their crops against fungal infections, and so they'll use antifungal drugs in that way. What's quite amazing, though, is that the same classes of antifungal drugs that are used in patients are also being used in agriculture, meaning that the resistance can then be kind of crossing over. So there really needs to be a big push and change in policy, really, to try and separate those more, to try and protect our patients better. And the reason I also wanted to bring this up is because I mentioned flower boxes. There's also been some evidence in some hospitals that the drug-resistant fungal infection that patients have, they picked it up from spores that were picked up in flower beds that were potted around the hospital. So that can be a problem as well, and something that I think needs to be considered, particularly if you think about air quality and ventilation in hospitals. So looking at that talk we had just before lunch, I was kind of curious if fungal spores might be something worth considering there. Okay, so the last disease I'm going to mention is cryptococcosis. This is one that we focus a lot in my lab. It's quite rare in the UK, but I'm going to explain, give a couple of examples of why it's still important here in the UK. So the World Health Organization put out its first ever fungal pathogen priority list about 3 years ago now, split into critical, high, and medium priority groups. So you can see Aspergillus I've already mentioned, and the Candida auris and albicans. But also in here is Cryptococcus neoformans. This is another environmental yeast, and again, it's found in lots of places. So pigeons are particularly big carriers of this. They produce the spores, and then we inhale the spores all the time. But as I say, if you have a nice healthy immune system, it won't cause a problem because your immune cells will destroy it. But in patients who have certain types of immune defects, these spores can then germinate, and then they can cause a type of pneumonia infection and then escape from there, and they seem to primarily go into the brain. And the major risk factor for this disease appears to be advanced HIV infection. So this is a really big problem for HIV-infected patients, and killing up to about 15% of all HIV-infected patients in the world will die from this disease, cryptococcal meningitis. The vast majority of cases are in sub-Saharan Africa because that's where the highest burden of HIV is. But we are starting to see in the last sort of decade or so an increasing frequency of non-HIV associated cryptococcus diseases. And this is typically affecting patients with certain types of cancers, but also organ transplant patients as well. So it's something that we need to be more aware of. This is what the infection looks like in a mouse brain. I don't know how well you can see that, but the green cells are the fungal cells. This is like a slice through an animal's brain that's been infected with the fungus. The red is immune cells, and then the blue is just like neurons and other types of cells in the brain. And what you find are these huge big holes that open up in the brain, which just fill with fungal cells. And we see this in autopsy studies of patients who've died from this as well. So it's a really very nasty infection that causes huge amounts of brain damage. And so even patients who survive this infection are typically left with a lot of neurological problems as a result of this damage. Now, it's quite rare to see this type of infection in the UK, but it has happened, and it has been linked with sort of poor air quality in hospitals. So in Glasgow in 2019, there was 2 patients who sadly died from this infection at the hospital. And we think it's linked actually with roosting pigeons. So there was found to be pigeons roosting near in the air vents and things like that in the hospital, which may have then caused them to, because we know that they can spread a lot of these fungal spores, suggesting that these patients might have had a very high dose of fungal spores, and that probably contributed towards them getting the infection and dying. One of the reasons we see a lot more patients dying in the UK from this infection than maybe we would elsewhere is it because doctors typically don't see this infection very often in the UK. It's not very well, and the awareness is not there. So there's not that high degree of clinical suspicion that's often needed for fungal infections to get the antifungal drugs in as quick as possible. And so this is some genetic analysis. You don't need to understand what this diagram. The point was to show there's been a lot of effort trying to understand where do these fungal infections come from their spores. And so that usually means analysis of the strains that killed those 2 patients in the Glasgow hospital, then shown in red. And all of these other strains were also compared genetically to try and figure out where these fungal infections are coming from. And I think that's really important because we need to know where these fungal infections come from, because we have this growing population of patients who have these immune system defects. They're not going to go away. If anything, they have been increasing. And it's very, very difficult to protect these patients from being exposed to fungal spores and things because they're everywhere. They're in the environment. And I think that just highlights the importance of having good air quality and ventilation control in hospitals to try and protect them as much as we can. So I'm going to finish there, just talk about looking ahead and what I think our field really needs. We desperately need a wider range of antifungal drugs. This is something we do in our lab. We're trying to find more targets, better targets, something that we can use maybe separately from the agricultural industry so that we can better treat our patients. That requires a lot more research and investment. Historically, fungal infections have been vastly underfunded and under-researched, but that has been changing in the last few years. We're now seeing huge investment for lots of funders, such as the Wellcome Trust, who are now making this a priority area to try and better manage these infections. And then the other thing I think we just need is increased awareness and education. It's one of the reasons I'm here. Hopefully you'll go off and tell people all about fungal infections after this, and make sure that people are aware of how important they are and how problematic they can be. I think I've just got one. Yep, I'm just going to one more slide. Just going to finish by acknowledging all of my lab members, past and present, and all my collaborators at the University of Birmingham, where I'm based. And I also have a lot of collaborators around the world, including in South Africa, Japan, and China, that we do a lot of work with there. And these are all the people who fund my research below. Thank you for your attention.